I want to talk a bit about teaching and learning in the operating theatre. You may not have thought of the operating theatre as a complex learning site, but I do think it is. Some of you will be familiar with the operating theatre, but for those of you who have not been in there before, you will find that there are very different professional groups operating within different zones around the operating table. And within each of these teams, especially in teaching hospitals, you will find a mixture of very experienced and less experienced clinicians. So it might well be that during any operation there are novices involved in each of these teams, which obviously complicates the work going on there significantly. Now, interestingly, we know very little about these intra-operative teaching and learning processes. If we just look at surgery, which is what I will be focusing on tonight or today, this is a systematic review that came out just a few days ago, and it was actually the very first review of the literature available in this area. And there are very few studies included in this review, I think about 34. Now, one reason why the operating theatre maybe has not received that much attention when it comes to teaching is that a lot of interest has been around simulation. Diane already mentioned that very briefly. In surgery, just as in dentistry and many other specialties, lots of money has gone into developing simulation-based learning environments. But of course, the operating theatre remains a key site of learning. There is nothing better, as I'm sure many surgical learners will agree, as operating in a real environment. There is so much that we can't yet replicate in the models that are available, even though they are getting better and better. Now, what I've been doing in the last 7 years or so is video ethnographic research. I've gone into a teaching hospital, spent a lot of time looking at operations and bringing video cameras to record what goes on. We used handheld cameras as well as the inbuilt cameras that you can find in operating theatres, as well as the laparoscope, which is now often being used in surgery. And I used that material to do a micro-analysis of what happens in terms of teaching and learning in this setting. We used a piece of software for that called ELAN, which is developed by linguists. I'm actually a linguist by background, as you will notice as we go through some of my examples in a minute. So my focus was very much on what was being said during teaching and learning in combination with these actions that are being performed. So what did we find? Well, first of all, it struck us that there is this very clear process going on in terms of learning to see as medical students move from studying textbooks to watching their very first operations, surgeons from a distance shouting something like, "That's the liver," and pointing with a grasper to a real liver, which is displayed on this monitor in this laparoscopic procedure. Of course, that real liver looks very different in real life as it does on the textbook. And then again, if you move closer into the operation, you become an actual member of the surgical team. You get to feel patients and you get to see things from even closer up. You get yet another view of what goes on. And in that process, you learn to see and feel like a surgeon. You learn to see and recognize the categories that surgeons work with to describe the world in surgical terms. What counts as a liver, what counts as a lipoma, how can we recognize them, and so forth. Now, what is interesting about surgery is that this seeing is very much tied up with the work of dissection. A lot of the structures that you will want to identify are hidden underneath all sorts of layers of fatty tissue. For instance, in this case, we're looking at a gallbladder against the liver bed, and it's that bit in the yellow square that surgeons are particularly interested in. This is what ultimately will present itself as Callow's triangle, and there are all these different structures that you can see in the inset that you will somehow need to be able to identify in that messy stuff up there. Now, what is interesting from a linguistic point of view is that process of seeing and identifying structures is marked in what is being said. So here we're looking at an interaction between the surgeons operating and right at the beginning of the operation, when things have not been dissected out very much, you will hear them saying things like, "Look at that, that's weird. I would go into that space. That might be the artery and that might be the duct. Can you see this anatomy? Just twisted. Yeah, it's really weird. It's twisting around each other. Yeah. And what's that's doing? It's torting Hartmann's pout over." But then, of course, gradually things do become clearer, and you will hear them saying things like, "You can see it pulsating as well, can't you?" "Yeah, absolutely. Yeah, it's definitely the artery." So there is a decrease in the level of uncertainty, or rather, there is an increase in the level of certainty that's expressed with words like, "Yes, it is absolutely the artery," as opposed to somewhere at the beginning where they might say, "It might be the artery." And of course, this is also very sort of tricky stuff. If you commit yourself to a particular reading, then you might be losing face a little later. If you claim to see that it's definitely the artery, when that's later it turns out it's actually not the artery, then you're losing face, as it were. So in any operation, there are points where difficult decisions need to be made. In the case of gallbladder removal operations, there is a point at which the surgeons need to decide whether it is safe to divide the cystic duct. But of course, they need to be sure that it is actually the cystic duct that they are looking at, and that it's not, for instance, the common bile duct, which is the structure that you don't want to divide, because that would create all sorts of complications. And so that moment is also typically marked in the interaction. At this juncture, you will hear a consultant who's operating saying something like, "I'm happy with that now," or he might say, or she might say, "Happy?" And in some other occasions, they might say, "What do you think?" So we can see the degree to which and how they involve their assistants, who are usually trainees, how they involve these trainees into this decision-making process. Now, the first one is a very common a scenario when the consultant is working with relatively junior trainees. Whereas this second scenario, where he's asking or she's asking happy, i.e. inviting them to express their view, is actually quite common in our data set with senior trainees. The third scenario is very unusual. We saw that on only one occasion, and we looked at 14 of these operations. If you then look at how the trainees respond to these different invitations or statements made by the consultant, you can see that, typically they agree with what is being said. Whereas only in the third instance, where there's actually an open invitation, an open question being asked, you get an actual view being expressed and a proposal for action being made by the trainee. So far I've only talked about consultants operating and being assisted by trainees, but of course what happens frequently is that the consultant hands over the scalpel to the trainees, and trainees are very keen to get their hands on the scalpel. Actually, just a few days ago, I noticed there is a discussion going on at the moment about whether or not that should be disclosed to patients. A lot of patients are not actually aware of the fact that the trainees do get involved in the operation and may actually do parts of the operation. And this surgeon suggests that it should be disclosed. Now, of course, the question then is, how can consultants maintain a degree of control over the operation when they hand over the scalpel to trainees? This is certainly something that the patient would want to know. Well, of course, first of all, the consultant will select very carefully an appropriate phase in the operation. It's very rare that the trainee will actually hold the scalpel from beginning to the end. And in fact, the scalpel may change hands very frequently, even once or twice per minute. Then, if we zoom into these episodes in a bit more detail, and again look a bit more carefully at what is being said during these operations, we can see that the consultant can actually maintain a fair degree of control by making these verbal instructions. And we do need to realize that that's actually the only mode of communication that is available at this point to the consultant, because the consultant, as well as supervising the operation, will also hold the camera, also hold a retractor, so he can't use his hands, for instance, to point at certain areas in the operative field. So he's very much relying on speech. And what he does is monitoring very carefully these actions that the trainee is performing with the scalpel. You can see that scalpel moving into a particular plane, then he will grasp a little bit of tissue, lift it up a little bit, and it's not until then that he will activate the ultra vibration that actually cuts through the tissue. So there is a bit of a time frame within which the consultant can intervene if he feels that he's perhaps not quite in the right place, or maybe too close to surrounding structures that must not be touched at all. And in the cases where we looked at this in more detail, that seemed to work really well. So here there's a couple of examples. Trainer saying something like, "I would go superficial to that actually," and immediately the trainee responds to that by repositioning the scalpel. So you could call that a form of correction. In some other instances, it sounds more like a warning. For instance, in the second episode where he says, "Just be a bit careful in the planes there, there's the ureter and things." And the ureter is one of these words that immediately prompts a trainee to withdraw the scalpel. Those of you who know what the ureter is will understand that. The third option is also quite important. So whenever a trainee is sort of ready to make that little cut as he's dissecting out a certain area, in this case they're actually working on the lateral attachment of the colon to the abdominal wall. So you will hear the consultant saying something like, "Yeah, that looks fine," before the trainee actually makes that final action, i.e. activating the electronic scalpel. So these are quite sort of useful mechanisms that help us explain why it seems to be possible to deliver patient safety, as well as providing opportunities for trainees to learn. I do have to say that there are, of course, also examples where you can really see that they are up to their limits in terms of what you can express with speech. And it's at those points that the trainee is likely, or that the trainer is likely to suggest that he takes over just momentarily and then hands back to the trainee. Because it's really tricky to, for instance, explain where you want the trainee to make that cut if you can't actually point at anything. And you would have thought that, that everything that you can look at in a body has a name, but of course it doesn't. So you hear surgeons talking about that bit of tissue over there. No, that stuff over there. Not everything has a name. So I want to leave you with a question. I think what I have shown you is one way in which we can use video to do sort of more detailed analysis of what goes on in a clinical area. I think we could do that in any clinical area within a hospital. And I think the video really has some added advantages, because a lot of what we think we know about clinical education is based on what people say in interviews. Interviews are, of course, a useful way of gathering information about people's experiences, but they are also reported behaviors, and there is a real advantage to actually having a video which you can use as a sort of shared point of reference. And it's something that can be analyzed by researchers, but it's also something that can be used by clinicians themselves in the context of debriefings, for instance. And given that in places like operating theatres there are now lots of cameras available, and it really just is a matter of pressing a button to make it record what happens, it seems to be a missed opportunity that this stuff is not actually being used. So I would make a case for using video more routinely. If you want to read more about that, there is plenty of stuff that we have written on this. I'll leave it there.